Today's lecture is about headaches. When we say headache, we could mean a number of things. For example, right now, I think that staying at home with 3 kids and still having to read, write, and record lectures, that's a bit of a headache. But that's not the kind of headache that we're talking about today. The headache that we're talking about would be pain in the head, exactly what it sounds like. Now, there's a few different types of headaches, and the image that we're seeing here, again, not the headache that we're talking about. The 3 types that we're going to bring up are going to be tension headaches. These are by far the most common. Migraine, fairly common, more severe, and cluster headache, the least common but the most severe. All 3 different types of headaches have the same thing in common, and that is they produce pain in the head. And anytime you have pain in the head, this is going to be caused by stimulation of the trigeminal nerve. Either that or the trigeminal nucleus. And in particular, we're talking about the spinal trigeminal nucleus. We'll get a picture of that in just a little bit. But that is the painful nucleus for the trigeminal nerve. The trigeminal nerve innervates the head, most of the head anyway. There's some cervical nerves that hit that and the shoulders, and those are going to play a big role in tension headaches. Those cervical nerves still feed into the trigeminal, and that's why we feel headache even when we have tension in the shoulders. So we'll review the different types, what they look like in terms of symptoms, prognosis, risk factors, and then we'll go through the pathophysiology of headache. Because in the end, they all have the same thing in common. Stimulation of the spinal nucleus of the trigeminal leading to pain in the head. Headaches are common. This has to be the most common problem that we're talking about in this class, because about 90% of everyone out there is going to experience a tension type headache at some point in their life. As you'll see here, migraine, cluster headache, far less common, far lower lifetime prevalence. The age at which the symptoms peak is pretty similar across groups, about 30s, up to about 40 years old. That's kind of the peak. Of course, onset can be before that, and tends to be. So think of a kind of a bell curve here, and that peak there is going to be, unfortunately, where I'm at, somewhere between 30 and 40. Cluster headaches are going to peak a little younger. And cluster headaches are a little unique in terms of the male-female ratio as well. Tension type headaches and migraines are more common in females than males, but that flips with cluster headaches being more common in males. Now the type of pain in the head is going to vary between these 3 different types as well. So with tension headache, it tends to be bilateral, just sort of a band of pain going around. It doesn't really tend to hit the eyes as much. You'll see a little bit of eye involvement with migraine. These tend to be unilateral though. Cluster headaches are also unilateral, but here we see strong orbital involvement, so the pain tends to be right around here. So the pattern can help us distinguish one from another, and there's of course other symptoms that will distinguish migraine and cluster from the tension type headache. So we'll start off with tension type headache because they're more common. The major risk factors here are really going to center around improper diet and really improper management of stress. When we're talking tension, we're talking really tension in the shoulders, and this is where we tend to put our stress. We'll kind of bunch up. Now it could just be from bad posture. You know, you could be sitting there typing away all day, and that can create a tension headache. But we also will tense up with stress. So negative coping strategies with stress is a major risk factor, as opposed to a positive coping strategy like exercise or meeting with friends and laughing away your stress. The negative coping strategies would be internalizing that, focusing on it, and kind of dwelling on it. Low levels of magnesium are also associated with headache, really any type, and that's because the low levels of magnesium are going to increase the excitability of those trigeminal neurons. So remember that magnesium is going to block NMDA receptors, and voltage-gated calcium channels. Both of these are excitatory. So when we have low levels of magnesium, we have less inhibition, therefore we have increased activity of these, leading to activation of the trigeminal nerve. And that's where it's all going to end in this first part. We'll pick it up from there in the second part. There's a variety of dietary factors that play a role in headaches. Missing a meal is a major contributing factor, but there's also a clear link between caffeine and headaches. So prolonged and high volumes of caffeine use can predispose some folks to developing headaches. I'm certainly very sensitive to this. Not everyone is, you know, we're all snowflakes. But some of us out there can really only tolerate about 1 cup of coffee. And if we miss that 1 cup of coffee, well, we're going to develop a headache. And so you can simply control your headache by just having your 1 cup of coffee. What these data are showing us are just a variety of dietary triggers that were identified through survey in Malaysia. Heaty foods, by the way, would include spicy foods, but other things as well, such as garlicky foods, foods with a lot of coriander or ginger. Those are also heaty. But you'll notice right at the top of the list, 2 things there: coffee, chocolate, both of which have caffeine. What caffeine is normally going to do is inhibit the trigeminal nociceptive afferents, TNA. Not the fun kind of TNA, but the trigeminal nociceptive afferents. Nociceptive, of course, being pain, and afferent being sensory. Now, why would something that inhibits our pain-sensing nerves cause headache? Homeostasis. So after we have a dose of caffeine and we have prolonged caffeine use, what's going to happen to the adenosine receptors that this is inhibiting? We're going to upregulate them. So when we miss our dose of caffeine, if we don't have our cup of coffee, then we don't inhibit those adenosine receptors. By failing to inhibit them, we now have a greater level of those excitatory receptors, and so now our nociceptive afferents are more excitable as a result. So we have to keep our daily dose of caffeine going to make sure that we don't have hyperactivity of our trigeminal nociceptive afferents. Now, aside from the actual pain in the head, the other symptoms that will accompany tension-type headaches would be muscle tension. That's why we're calling them that's why we're calling them tension-type headaches. Tension in the shoulders is not uncommon with these. Have a look on the bottom here. This is just showing us the dermatomes for the trigeminal nerve and the cervical spine. So the top about 5 levels or so is going to take us all the way down to about here. And those cervical roots are going to feed into the spinal nucleus of the trigeminal. They're calling it something a little different here. I think it looks like it says trigeminal cervical nucleus. Same thing. Spinal nucleus of the trigeminal. This is where pain-sensing neurons are going to feed in, and from the trigeminal nucleus, so from that spinal nucleus of the trigeminal, it's the 5th nerve, we're going to head up into the thalamus, and from there go to the cortex, and we will feel pain due to this input. And not just pain anywhere, but pain in the head. In other words, headache. Exactly what we're talking about today. We can have input from the trigeminal here. There's 3 different branches. They'll all feed in here. If they're pain sensing, this deals with pain. But we also get input from cervical nerves as well. They hit further down. They didn't do a great job there. But they all are going to feed into this spinal nucleus of the trigeminal. So you'll see it's going to run from about the pons down into the cervical spinal cord. So it's a massive nucleus, going to get everything in the head, not just the trigeminal, but also the cervical nerves that are serving the back of the head and the neck. They feed in there. So anything that's going on here as far as pain is concerned is going to seem like it's happening here. So that muscle tension is going to stimulate the pain sensing nerves and create headache. We'll get into how in the next part. So that kind of dull throbbing pain in the head, this could occur very infrequently. We could call it episodic if it's going to be fewer than 12 days out of the year. Anything more than that, we're going to call it chronic. With tension type headaches, we shouldn't see nausea and vomiting. We shouldn't have any aversion to light and sound. That's going to come on more with migraine. As far as prognosis goes, it kind of depends on how severe the headaches are and how well you manage that stress that's undoubtedly underlying tension headaches. So those negative coping strategies. Not only are they a risk factor for developing the headaches, they're also a risk factor for developing chronic headaches. So get out there, exercise, and meet up with friends, but stay 6 feet apart. The remission is a little more common in females, but then again, the headaches are more common in females, so I guess that makes some sense. And if you don't have medication overuse or misuse, because the use of painkillers can actually cause sensitization of pain neurons. Again, homeostasis, kind of like what happens with caffeine. As far as management goes, fairly simple. Take some NSAIDs, have some lifestyle changes, so anything you can do to develop positive coping strategies or to ensure that you're not missing a dose of caffeine, you're not taking too much caffeine. Nice, low amplitude doses. Maintain a normal frequency of them so you don't have big swings in your caffeine levels. Exercising can help. Migraines are going to be a little bit different. So here it's not the muscle tension that's causing a problem. Here it's likely going to be some sort of channelopathy, so a mutation in an ion channel. There's a strong genetic risk here. So most cases have family histories, and what we're looking at here would be the inheritance of a dominant negative mutation in a potassium channel. Now, there's a ton of potassium channels out there. This is a very large group of proteins, and so different neurons will have different types of potassium channels. They're all going to basically do the same thing, and that is inhibit the neuron. The potassium channel that we're talking about here, TRESC, this is expressed highly in the trigeminal nucleus. So in that spinal nucleus of the trigeminal, here's your potassium channel. And that dominant negative mutation is going to increase the excitability of those neurons. So you can look at the inheritance there. The different numbers are just showing you some single nucleotide polymorphisms. So the figure on the right doesn't matter that much. It's just showing you a dominant pattern of inheritance. The figure on the left there is showing you that we have no potassium currents in this case. So that tells us it's a dominant negative mutation. So without potassium, because our potassium channels are going to inhibit the activity of these neurons, well, we have a mutation and they no longer conduct potassium, so they don't inhibit, and therefore the neurons in the spinal nucleus of the trigeminal are more active as a result. There's also an association between fluctuations in hormones and migraine pain. So there's a number of things that are going to affect the activity of trigeminal neurons, and anything that makes them more active is going to stimulate migraine. Now, as far as symptoms go, there's again that more unilateral pain here, but in this case we might have a preceding event called an aura, which is going to include some sensory abnormalities, usually lowered mood, and those sensory abnormalities can include the scintillating scotoma that we're seeing an example of here. So there's kind of a hazy light surrounded by the shimmering or the scintillating multicolored lights. There can be paresthesia as well, usually in the hand and face. So we can have some abnormal sensation there. The aura precedes, in some cases, the migraine. Now, during the migraine, we're going to have that unilateral throbbing pain anywhere from 4 to 72 hours. And in this case, we're going to have an aversion to light and sound. So the best thing to do here is to go into a dark room where it's very dark, very quiet, because that light and that sound will cause pain. In a complicated migraine, during the migraine, we can then have some paresthesia or some motor weakness accompanying it. Now, as far as prognosis goes, there is some reported increased risk of stroke, but this is only true in cases with aura, and it's not that great of an increase. You'll look at the odds ratio there and have a look at the confidence interval. We are including 1, so it's a barely significant elevation here, but it is an elevation. The remission here is going to be more likely with, again, fewer headaches, so the less severe it is, the more likely you are to get better, and the absence of allodynia. So again, the less severe it is. So if you have non-painful touch causing pain during the migraine, it's less likely to remit because it's a more severe case. The last type here would be cluster headache. With cluster headache, this is going to occur a lot more commonly in males, and particularly males with depression and substance abuse, and with a family history of cluster headache. So again, we're seeing heritability here. So it's not muscle causing it. There's some intrinsic neuronal mechanism causing this, and rather than directly acting in the trigeminal, we'll see here that it actually has to do with the hypothalamus. And that explains those sleep abnormalities. So it takes longer to fall asleep, that'd be the longer sleep latency. And then we see difficulties with breathing during sleep. So elevated apnea and hypopnea index. So apnea would be the absence of breathing, and hypopnea would just be very low levels of breathing. And the cluster headaches can come on during waking hours or even during sleep. So what we're looking at here is an example of over 2 nights the onset of 9 cluster headaches in one patient. And you'll see that they come on during waking, so that'd be cluster headache 1 on top, or they'll arise during REM sleep or during deep sleep. It doesn't really seem to matter, but you'll see kind of a regular interval of cluster headaches arising. The headache severity here is the worst for cluster headache. So again, unilateral, but instead involving a lot of the eye. They're not going to last as long as a migraine, but they're going to be more severe. And we're going to see some autonomic dysfunction occurring here as well, again, hinting at the involvement of the hypothalamus, because the hypothalamus is going to regulate those preganglionic sympathetic and parasympathetic neurons so that our emotions can create those bodily responses. So when the hypothalamus is hyperactive, that's going to cause an increase in autonomic output, and we see that. We'll see sweating, we'll see tearing, we'll see the production of mucus. So we're going to have a combination of sympathetic and parasympathetic output there, and the vasodilation that occurs during this can actually compress the sympathetic fibers that are rising up to innervate the eye, leading to Horner's syndrome. So we're going to see constriction of the pupil and a little bit of a drooping eyelid in that case. So the prognosis is worse here than with all the others because cluster headaches are so severe. They tend to cause loss of job as a result, and they can create disability. They can also lead to suicidal ideation because they're so severe. There's a mixed progression here too. Some patients are going to get better, others worse. You'll see kind of waxing and waning of symptoms. You might see complete remission, perhaps a reduction, or even no change. So it's a mixed bag as far as cluster headache goes. Now, regardless of the type of headache, the underlying cause is going to be stimulation of the spinal nucleus, the trigeminal, leading to the perception of pain in the head, because that's what a headache is, pain in the head. So it has to involve the trigeminal nerve. That's what's going to go on here. It is not going to be because of abnormalities in the size of blood vessels though. So this is an outdated idea. I don't want you leaving this class thinking that you get a headache when your blood vessels get too big in your brain. That's not what happens here. So that theory makes a whole lot of sense until you look at the data. But the face validity is excellent. Just none of the other validity is. So the reason that I say this is because it's true and because of these data that we're going to go through here. So you can look at the size of blood vessels and you can change the size of blood vessels. So here's how we can look at the size of blood vessels. This is just using MRI, and you can inject compounds that are going to make the blood vessels light up. So when you inject nitroglycerin, this is going to cause vasodilation. So you can initiate the vasodilation of vessels, and sometimes you'll get a headache, sometimes you won't. So here we're looking at either the injection of nitroglycerin or placebo. And with nitroglycerin injection, if they got a migraine or not, they've separated them out. And we have 3 time points that we're looking at on X. We got baseline, we have the scan after giving nitroglycerin or placebo, and then we have at the onset of migraine or just after 60 minutes. If they didn't develop the migraine, or 6 hours, sorry, 6 hours if they didn't develop the migraine. On the y-axis, we're looking at the diameter of different blood vessels. And regardless of where you look, the story is going to be the same. So this would be the middle meningeal artery here. When you give nitroglycerin, whether they got a migraine or not, doesn't matter. You'll see in that middle section, we have vasodilation. So the blood vessel gets bigger. It gets bigger whether they got migraine or not. But during the migraine, it's not bigger. Notice it dropped right back down during the migraine. Having the big blood vessel doesn't cause the migraine. And you'll see the difference between those who got nitroglycerin and developed migraine or didn't, they have the exact same pattern. So what we can see here is that nitroglycerin causes vasodilation, and sometimes it causes migraine, sometimes it doesn't. Placebo doesn't cause vasodilation, but some people still get migraine with placebo. You don't see any correlation between the size of blood vessels inside or outside the brain and migraine. So don't think that. It's not caused by some overt change in blood vessel size. Now, changes in the vasculature could cause some of the components of headache, such as the aura that precedes migraines. So if we have some sort of mild ischemia, that might explain some of the visual abnormalities like that scintillating scotoma. But no, headache all comes down to abnormal activation of the trigeminal nerve, not because of overt vasodilation. It's all about that trigeminothalamic tract, and particularly the fibers arising from the spinal nucleus of the trigeminal. So we've got 3 neurons we need to think of here. We got our primary neuron. Now in the case of tension headaches, I'm going to draw the back of the head here, so they're looking away from us. The shoulders here are going to be innervated by C5, C4, something like that, and these are going to feed in then to the spinal nucleus of the trigeminal. So we got input from our primary afferents. And the primary afferents could be from the cervical spine. That's what we'll see with tension type headaches. Or they could be from the trigeminal. And this is a little more likely with migraine. These all converge here on the second order neurons in the spinal nucleus of the trigeminal. From here, we head on up to the thalamus again, then to the cortex. So the thalamic neurons will be our third order, and when we hit the cortex, that's where the magic happens. In this case, the magic would be headache. Now, when we're talking about nociceptive afferents, what they're going to do is sense pain. Now, what pain is really either heat or a change in pH. So when things become acidic or very hot, very cold, that's what heat is. These fibers here are thus going to be, let's say, stimulated by, we'll say, a drop in pH, and they're going to be inhibited by serotonin. So we have a way of treating, and we'll get to that later. I mean, have an idea of what's causing tension-type headache here. So there's our primary afferents for the trigeminal, shown in this illustration. And here we're looking at a few different trigeminal nuclei. You'll notice that spinal nucleus is going to run from the pons down into the spinal cord. We're going to head on over to the thalamus and then to the cortex to produce that pain in the head. Now, pain is very instructive, and there's a variety of feedback loops that are going to prolong pain. Now, the first one happens at the site, where the axon is innervating the skin and muscle in order to sense pain there. So whenever we stimulate the pain-sensing neuron here, let's say we have tension, that prolonged muscle activity dropped the pH, and now we have pain. It's going to lead to headache. The stimulation of that axon there, let's say here's my axon, so free nerve ending. When this fires an action potential, what it's also going to do is spit out some neurotransmitter. And that neurotransmitter is going to act on local inflammatory cells. In this case, mast cells. So there's a few of these that could be spit out here. Calcitonin gene-related peptide and substance P are some examples there. These are going to stimulate mast cells, and then mast cells are going to spit out things like histamine or prostaglandins. This is going to not only help stimulate an inflammatory response, but it's also going to excite this axon so it fires some more action potentials. This reflex right here is what we call the axon reflex. And this makes areas that are damaged or experiencing pain more likely to feel pain if they're touched again. So we tend to hide them away and allow the recovery process to occur. The cartoon here is just showing you a little more elaborate graphic illustration of this. So there's a few ways where we amplify pain. Here's one out there in the axon of the primary neuron. At the cell body of that primary neuron, we also have peripheral sensitization occurring. Pretty much the same thing. When this neuron's firing its action potentials, it's going to release neurotransmitter, in this case, calcitonin gene-related peptide. And this is going to, instead of acting on mast cells, it's going to act on local glia, the satellite cells, which will then release pro-inflammatory substances, stimulating not only an inflammatory response, but also our primary afferent. Now in this case, rather than just stimulating another action potential, here we're going to actually alter gene expression so this neuron becomes more excitable. So we'll have a greater number of, let's say, sodium channels, for example, and we'll increase the synthesis of neurotransmitters as well. So this neuron is more likely to be excited in the future. And this will persist as long as we have that damage. We could also have sensitization in the spinal cord. Now this is probably a little more than we need to get into here, but this is essentially learning gone awry. So just like we talked about in epilepsy, where we have neurons firing together and wiring together, whenever we have prolonged pain, well, that can actually lead to improper learning in the spinal cord, or central sensitization. The same thing as long-term potentiation, but just like with kindling, the people who study it want to call it something else. It's all in branding. It has to do with money, of course. It's the same thing though. It's an increase in synapse strength, but in this case it's learning gone awry. And this can lead to the increase in, let's say, headache severity, for example, that progression from episodic to chronic. So if they're not managed, that learning can take place at the level of the spinal cord here. We'll talk more about this next semester, but what's going on here is really just neurons firing together and wiring together, just like we've talked about before. So that NMDA receptor has the magnesium block. So only when two neurons are active at the same time, let's say here's my primary afferent, here's my secondary afferent in the spinal cord. If they're both firing action potentials at the same time, stimulation of the NMDA receptor can occur. Otherwise, no NMDA, all AMPA. When we stimulate NMDA, because this was depolarized, we then affect gene expression. That's going to cause an increase in neurotransmitter receptors so that this synapse is stronger. And this is fine as long as it occurs transiently and goes away after the pain has been removed. Okay, so for tension type headaches, constant muscle activity drops the pH, stimulates the primary afferent, bing bang boom, pretty simple. With migraines, well, we might have some sort of channelopathy, like let's say a calcium channel mutation either in the primary afferents or here in the secondary afferents. So if we have mutant potassium channels and we're no longer resting at minus 70, instead let's say we're resting at, oh I don't know, minus 60 millivolts or something like that, we're far closer to threshold and more likely to fire action potentials even when we shouldn't. So we'll experience pain in the head a lot more frequently. With cluster headaches, the issue here is going to be in the hypothalamus. So here's our pituitary, and up above that we got our hypothalamus. Now there's actually a projection from the hypothalamus down to the spinal nucleus or the trigeminal. So when you have hyperactivity of the hypothalamus, not only will this give you issues with sleeping, because the hypothalamus regulates our circadian rhythms, it's also going to stimulate secondary nociceptive afferents in the spinal nucleus of the trigeminal, leading to headache. As far as treatments go, again, you have your analgesics and NSAIDs. Those can be helpful in reducing inflammation. Inflammation is going to play a role in creating pain in those primary afferents there. Exercise can help. What these data are showing us would be the activity of triptans, and triptans are serotonin agonists. These are going to act on receptors on the pain-sensing primary afferents there. These serotonin receptors are inhibitory, so by stimulating the inhibitory serotonin receptors, we are going to inhibit our primary afferents. So by essentially boosting serotonin signaling, we decrease the input to the spinal nucleus of the trigeminal and decrease headache. So these data are showing you whether we're looking at 2 hours or 24 hours later on the left and right respectively. In mild or severe headache, we see a reduction in pain that is much greater than placebo. In the cases of chronic migraine, Botox injections throughout the head can be useful in damping down the activity of our primary pain-sensing afferents there. And for cluster headaches that aren't treatable with a non-surgical route, deep brain stimulation of the hypothalamus can help silence it. So again, deep brain stimulation is not stimulation, even though it has it right there. That's going to inhibit the hypothalamus and thus relieve pain. Now I have some pain that I need to go relieve in the other room. Here's some review questions for you. Have a look at those. If anything doesn't make sense, fill out the questions box and I'll address that in one of our Zoom meetings. I'll see you later.